Hey everyone, Dr. Heisel here. Today we're talking about proprioceptive neuromuscular facilitation, which we have talked about in regards to improving range of motion with those PNF stretching techniques. There are also several other indications that proprioceptive neuromuscular facilitation can help with. So today we'll kind of talk about applying PNF techniques to different impairments that a patient might have. There are several techniques that we'll talk about today. And there are also the supplemental videos that I have posted of Dr. McLennan kind of working through these techniques as well from when he previously taught this course. And then the next week in lab, we'll work on applying these PNF techniques to clinical cases and kind of getting some hands-on practice for how to apply these PNF techniques to different impairments. If we look at defining PNF, we know what all these terms mean, but proprioception is referring to that sensory awareness of where our body is in space and what movements our body is doing at the time. Neuromuscular is talking about where the nerves and the muscles meet to kind of promote that activation of the muscles. Facilitation refers to a technique that's used to get a response, to get a motor stimulate, or to stimulate a neuron with different techniques that we can use. So we'll talk about some today. A lot of this PNF content will actually talk about and apply to stroke survivors and TBI survivors when we're in Neuro 1 next semester. So we'll kind of talk a little bit about today how those techniques could be used. So PNF, when we think about it, we talked about with stretching the muscle spindles and the Golgi tendon organs, but really those sensory receptors are important for getting that input and then also to produce and amplify the amount of motor output that we get. So, it's taking that proprioceptive, it's cutaneous receptors, it's auditory receptors. So with PNF, you're going to provide proprioceptive input, you're going to provide cutaneous input through where your manual contacts are, and you're going to provide auditory input to the patient based on like what verbal cues you are giving. We'll also talk about PNF diagonals, which probably make up the most complicated portion of this lecture. So again, like as we're talking about the diagonals, I would recommend just pausing it and going to the supplemental videos from Dr. McLennan about the different diagonal techniques. He does have two separate ones. One is just him doing it himself, which I would recommend you practice and get familiar with doing those movements yourself, because how are you going to teach a patient how to do it if you can't quite do it yourself? So just getting some practice on yourself, and then in lab we'll practice doing it on patients and as we work through patient cases. But these diagonal patterns are comprised of multi-joint, multi-planar, rotational, and diagonal movements. So we've talked about before that life doesn't occur in a single plane, and these PNF diagonal patterns kind of came up to kind of emphasize that we rely on multi-planar, multi-joint movement to perform functional tasks throughout the day. We talked about using PNF techniques for improving range of motion, but it can also be used for strength and endurance within the muscles. It can be used for stability, for more like postural control. It can be used for mobility, like with those diagonal patterns we talked about, neuromuscular control, providing those different inputs to encourage that facilitation of movement and that neuromuscular activation. It can be used to develop coordinated movement, within whatever diagonal planes we're working in. We talked about one of the downfalls with active range of motion, just like uniplanar shoulder flexion, is that it's only going to improve coordination within that movement. So with the PNF diagonal techniques, it's going to improve coordination more within a functional multiplanar, multi-joint movement. Another good thing, and kind of where it becomes useful with working with patients with neurological deficits, is that we can really modify just how difficult it is. And we can even just start with passive range of motion and moving them through the passive range. And then if they're starting to get some activation, we might work on isometrics, and then progressing to more active assisted movement. And we can even progress it to more power-based movement where we're moving at quicker velocities, or we can progress it to providing some significant manual resistance to work on strengthening. So really, you can use it along a patient's kind of all along their recovery from beginning to end, based on what they have and how much they get back. It is, if you talk to PNF purists, and I feel like there aren't as many around as there used to be, they're very specific with what tactile cues and what verbal cues you provide the patients with. So it does require you to provide tactile and verbal cues that are facilitating that movement. So, with where your hand placement is going to really determine what type of reaction, what type of muscle facilitation you get from the patient. So always keep in mind, and we'll talk about this a lot more next semester, but if you're working with a patient and not quite getting the movement or what you desire from them, it's probably could be related to where your hands are, what manual cues you're providing, and sometimes where your hands are might contradict what verbal cues you're providing. So you really want to maximize the use of your manual cues as well as those verbal cues to really get a strong, powerful quality contraction in the muscle. We have a lot of terminology to talk about with PNF. One of the concepts is overflow. It's also known as irradiation. One tough thing with this PNF lecture is there are multiple names for several of the different techniques and different terminology that we'll learn today, so that can make it really difficult for a learning purpose. But overflow means that if we resist those stronger muscles, then sometimes we get an increased muscle response to those weaker muscles. So say somebody has pretty strong proximal strength and you're resisting a shoulder flexion component of one of these diagonals, that might cause some irradiation to the elbow or to the wrist where those muscles are kicking in a little bit more. And again, this overflow is primarily achieved through the application of manual resistance while a patient is doing it. Those manual contacts are important, and like I said on the previous slide, it's very important where your hands are, because where your hands are is going to either stimulate and kind of facilitate muscle recruitment, or it could even inhibit muscle recruitment. And if that's not your goal, you're not going to get the motor output that you want from this patient. So, our manual contacts are going to kind of vary depending on if we are more kind of guiding the patient through the movement and kind of directing them through it, or if we are resisting the movement and we want them to push into us. So, again, you'll get some practice with the manual contacts in lab. When we think about therapist position, again, it kind of falls along with body mechanics, but we want to be in line with the desired motion that we're trying to get from the patient. Dr. McLennan does a good job in the PNF diagonals videos where he's moving his wife through the diagonals. He shows you and specifies like where you want to be. But this comes equally important, or even more important, when you are providing resistance, because if you're in line with the movement, you can really generate more resistance for the patient to have to fight against. So your position will be important as far as it plays into body mechanics and things like that. Approximation, or kind of bringing those joint surfaces together, which typically happens with weight-bearing positions, either like a quadruped position where a patient's on their hands and knees. We'll get pretty good approximation through the shoulders as well as or through the entire upper extremity as well as through the lower extremity. So approximation can be helpful with getting that muscle force. So, always kind of consider what muscles you want to work and what role you want them to work in. But if your goal is stability, approximation might be something that you use. And just really what this keeps in mind with is how you position the patient when you're doing it. Are you getting approximation through the upper extremities and lower extremities, or just the lower extremities alone? Traction is kind of more like bringing the joint surfaces apart, and sometimes that can be used during PNF patterns to facilitate a muscle contraction. So if you think about like those stabilizer muscles, like if we're trying to kind of, and this is something you gently do, you don't just grab their arm and tug on it, but you gently apply a little bit of traction, trying to draw that glenohumeral head, or the humeral head away from the glenoid fossa. And that's going to cause some activation of those rotator cuff muscles to kind of help stabilize the humeral head on the glenoid fossa. So sometimes applying gentle traction can be useful to facilitate a motor response as well. Talked a little bit about cueing, but cueing is huge in PNF. So really, like with the verbal cues, we want the patient to know what we have planned and what they're going to do first. So we need to give those preparatory cues. We might explain what's going on, what movement we're working at, and we might even demonstrate as we are giving those preparatory cues, just so the patient knows what we're doing and what we're trying to get from them. But really, as the patient is going through the movement, you want to really be energetic and strong with the cues that you're providing, because it's really shown that by you having that energetic and giving those strong verbal cues, that it improves the muscle facilitation and motor recruitment that the patient achieves through that cueing. Visual cues, you really want the patient to visualize the distal segment, and this is more for like the PNF diagonals too, where they're moving throughout multiple planes, but you want them, as they're doing it, to watch what their distal segment is doing. And again, depending on what position they're in, they might not be able to look down at it and visualize it. You might need to use some mirrors to kind of help with that, so that might be useful. Timing, you are with the diagonals looking for fluid movement. So, you kind of want fluid movement. Usually it'll be like an initiation of the distal segments first, but then kind of moving through the proximal. It's not like you just move the wrist first, then the elbow, then the shoulder, but usually the movement is initiated distally and then moves proximally from there. But these PNF diagonals also encourage rotation throughout the joint, which occurs throughout the entire movement. With manual cues, that can be, sometimes our manual cues are to guide the patient through the movement. Sometimes it's to apply resistance if our goal is strengthening, or sometimes it's to apply a quick stretch, which can be a useful technique for facilitating a muscle contraction. I've kind of reorganized this from last semester and tried to kind of break it down on what your goal is, what you're working on with these techniques. I think the majority of these techniques, except for the lift, reverse lift, chop, and reverse chop, there is a corresponding video on the Canvas page that you can check out. There actually is one. Rhythmic initiation does not have its own video, but if you look at the first, it's actually like the second set of UE diagonals video where it shows his wife's lying on the treatment table, because he's showing how to perform it to a patient. He does talk about rhythmic initiation there. The repeated stretch or repeated contraction is talked about during the quick stretch video as well. So with the exception of the lift and chop and reverse lift and chop, there is a video. It is discussed in all of those different videos from Dr. McLennan. So check those out again if you want to kind of pause it and look at it as we're going through these. He does break down the upper extremity and lower extremity diagonals a little bit more. So you might want to pause it, watch those videos, unpause, and come back to this and kind of see. Or if you just want to watch this all the way through and then watch the videos at the end, while you have the PowerPoint pulled up, you can do that as well. But kind of one of the biggest things that comes about, and a lot of times what people think about when they talk about PNF, is the different diagonal patterns that we had talked about a little bit, just kind of looking more at these multi-joint, multi-planar movements that also encourages like rotational movement throughout the extremities, trunk, and it can be performed at the neck as well. There are two pairs of diagonal patterns for each the upper and lower extremity, and they're kind of paired together, and we'll talk about the different movements that occur throughout these, and then if you want to see them, watch those videos from Dr. McLennan. I think the videos I think there's like over 20 minutes, like if you watch all of the videos once, so some of these might take a couple of times watching. Diagonals are referred to, so we talked about we have D1 flexion and D1 extension, D2 flexion, D2 extension. They're identified by the position of the shoulder at the end of the diagonal pattern. So that shoulder will be in relative flexion or extension at the end of the diagonal pattern, and that's what we're referring to when we talk about D1 flexion and D1 extension. At the proximal joints, so either shoulder or hip that we're moving at, we do have flexion or extension in which it is named after, but we also have abduction or adduction and internal or external rotation, depending on what the movement is. So it's not just working through that single plane of going through flexion or extension throughout the sagittal plane. We're moving through multiple planes as we do it. And encouraging multiple movements at the shoulder joint, which makes it a lot more functional to kind of tie into ADLs. And again, with these diagonals, we're getting multiplanar movement at the shoulder, but we're also getting movement at the elbow, wrist, and hand, as well as like through the forearm. So, this is kind of occurring pretty simultaneously. We might initiate distally and then work up from there, but a lot of times, just like functional activity, these movements, these multi-joint movements, are occurring simultaneously during each diagonal pattern. So this slide is showing the different D1 flexion, D1 extension, D2 flexion, D2 extension for each movement, what muscles are activated or what movements are occurring at the joints. There's a couple of different ways you can do this. One is just memorize this chart, kind of look through it, know that D1 flexion is shoulder flexion, adduction, external rotation, forearm supination, wrist radial deviation, and finger flexion. And then, for D1 extension, it's the opposite of that. You can learn it that way. On the next slide, I'll show you kind of how I prefer to learn it. So we'll look at upper extremity D1 flexion. Really the way I learn it is by just knowing what the starting position and what the ending position with each of these is. And if you know that, you know what is occurring at each joint. So the starting position for D1 flexion is actually the end position for D1 extension. So you can see in the picture on the left side, that shoulder is relatively extended compared to the ending position of D1 flexion. D1 flexion is referring to movement from the starting position to the end position of D1 flexion. So D1 flexion is actually movement from that extended position into that flexed position. It's not just the end position is not D1 flexion, it's actually the movement from the starting position to the end position for each of these. So, if you think about it, with the starting position for upper extremity D1 flexion, starts with that arm down and the palm is facing down. Verbal cue is to turn the palm up and pull up and across your face to get to the ending position. So this movement itself is D1 flexion. Kind of think about functionally, what tasks might be important for this movement and each movement as we go through these. But one way to remember upper extremity D1 flexion is to reach up for your seatbelt. So just kind of bringing that arm from down by your hip to up and across to grab your seatbelt is that upper extremity D1 flexion. So it's bringing your hand from your side, bringing it up to grab the seatbelt. And the end position would be grabbing that seatbelt over your opposite shoulder. Upper UE D1 extension would be thinking of pulling that seatbelt that you just grabbed at the end of D1 flexion. The D1 extension is bringing it down, pulling the seatbelt down and buckling it up. So D1 extension, we're moving from a flexed shoulder position to a extended shoulder position. So if you look back at the previous slide, this is just the starting position and end positions are reversed for this. So the starting position for UE D1 extension is the ending position for UE D1 flexion. So where they're holding that seatbelt, the ending position is where they have that hand back down by the side with the palm facing down. So the cueing for this would be open your hand and push your arm down and out as they do that. So if you can remember starting position and ending position, you can kind of look through and see what motions are occurring at each joint. Moving on to D2 flexion and extension, starting with D2 flexion. This one, the thought is draw your sword. So you have in the picture here, he's got his right hand down, his arms internally rotated, adducted, with the forearm pronated, and his hand is down near his opposite hip. So this is the start position of D2 extension. The verbal cue then would be open your hand and lift your arm up and overhead, and you want to make sure that they keep their thumb pointed out, as is shown in the picture. It's kind of pointing down towards the floor to really encourage that rotation through there. Upper extremity D2 extension. So you already drew your sword in D1 flexion. Upper extremity D2 extension, you're putting your sword away. So that starting position is going to be the ending position for D2 flexion. And then the end position for it is going to be that hand back down towards the opposite hip. So the verbal cue with this one, pull down and across your chest, turn your thumb down. So we have the UE diagonals. We also have lower extremity diagonals. I feel like the upper extremity diagonals are tied in a lot more to like common everyday functional things, not necessarily the drawing your sword, but part of lab will be trying to think of just different functional activities that the D1 flexion and extension and D2 flexion and extension for upper extremities would be used for, which those are a lot easier to find than kind of thinking of functional things for lower extremity diagonals. There are some, But I just feel like a lot of this multiplanar stuff with lower extremity diagonals is not as common in everyday life, but there might be some more like sport specific things that you might think of, and you might have a patient that might be appropriate to work on with them. So for lower extremity D1 flexion, this is kind of pulling your leg up and across. So they're started with their hip internally rotated, their hips abduction. They have ankle plantar flexion and eversion, which is the end position for D1 extension that we'll talk about next. Cue that you provide a patient is pull your toes up and bring your leg up and across your body. So, you're having the patient pull their leg up and across the body with the patient or with the therapist's manual position or hand placement in this, the manual cues she's providing. She can either help guide the patient through it, or if the patient is pretty good with moving through the movement, she might provide some resistance for the movement. D1 extension. So you're starting at the end point of the D1 flexion pattern, and you're thinking the patient is pushing their leg down and out. So the patient started with that hip and knee flexed, the hip in external rotation, ankle is dorsiflex, the ankle is in dorsiflexion and inversion. And then you're cueing them, point your toes, push down and out towards me, and you're having them work through extension through the hip and the knee, internal rotation of the hip as well, ankle plantar flexion, and eversion. D2 lower extremity D2 flexion is kind of known as the frog leg position. Starting position, that hip starts in extension, hip is externally rotated, knee is extended, ankle is plantar flexed and inverted. And then you cue the patient to bring your foot and toes up, move your lower leg up and out. So as the patient's doing this, they're flexing at the hip, they're internally rotating the hip, they're flexing at the knee, dorsiflexing at the ankle, and dorsiflexion and some eversion at the ankle. Lower extremity D2 extension is moving from that frog leg position in the previous one and returning to the starting position there. So starting position is that frog leg position with the hip inflection, internal rotation, abduction, the knee is flexed, ankle is dorsiflexed and everted, and then you're going to bring that hip into extension, external rotation, adduction, the knee is going to extend, the ankle is going to plantar flex and invert. And the verbal cue you would give the patient prior to doing that movement is to push your foot down and bring your leg in and across your body. All right, so these next few are not on the are not a part of the video series that Dr. McLennan had for when he taught this class. We might spend a little bit more time kind of talking through this in lab. Usually the way these lift and chop patterns are named are it's kind of assumed that the patient has one extremity that is stronger than the other. So it could be an incident where somebody's had a stroke or a TBI and they kind of have focal involvement of the contralateral upper extremity. So with this, it's kind of combining one of the extremities is doing D1 or D2 and the other extremity is doing the other one. So for the lift pattern, the involved side is doing that D2 flexion. So in this, you can see the patient's involved side is her left arm. She's using her right arm, kind of grasping at the wrist to help move her left arm through the movement. So the involved side, the weaker side, is doing D2 flexion, which was that draw your sword cue, while the uninvolved side is doing D1 flexion, which would be that grab the seatbelt cue that was provided. And left-sided reverse lift is just returning to the starting position, which then would be the involved side performing D2 extension, which is put your sword away, and the uninvolved side is performing D1 extension, or the buckle your seatbelt one. So again, these are named according to are kind of paired, assuming that one side is weaker than the other. It kind of becomes tricky when you want to use these patterns to kind of encourage bimanual bilateral upper extremity movements and movement patterns, but one side isn't weaker than the other, and that's kind of where the confusion might come in a little bit with this. But as far as like if any test questions or practical scenario, I will have one side be weaker than the other to make this kind of an appropriate thing to do. But it does become a little wishy-washy when we're talking more about like kind of, well, they're just weak in both arms, but it's pretty symmetrical kind of thing, and they don't really need to provide that active assist range of motion. But these can be good self-active assist range of motion techniques to train a patient to do, especially to get that multiplanar movement. A lot of times as a patient is improving, you might tell them with your good side, with your uninvolved side, just help as little as you need to as you're doing it. You can see, like with the therapist hand placement, it looks like she's providing some resistance to the right side. And if we think about, and we talked about, one of those concepts is irradiation, kind of with that, she's getting some overflow she's resisting the strong side, moving into D1 extension, but that might cause some overflow or some irradiation to that weaker side that's moving through D2 extension. So sometimes even just providing resistance to the strong side during a bilateral upper extremity movement could be a way to increase activation of the involved side. And again, that's a concept we'll talk about more in Neuro 1, but this is definitely a good place to introduce it to you. Right-sided chop, and then we'll have reverse chop on the next slide. With the right-sided chop, with this one, the involved side is performing D1 extension. So again, D1 extension is buckling your seatbelt. The uninvolved side is performing D2 extension, which would be put away your sword. So in this picture, the right side is the involved side performing D1 extension. The left side is the uninvolved side performing D2 extension. Again, one good thing that this picture shows is that you can do these in various positions. The lift and the reverse lift were shown with the patient seated, but you can also perform these in tall kneeling. You could perform these in standing. You can perform them in half kneeling, where they're kind of in this position. One knee is down, the other foot is down, kind of in like the bottom of a lunge position. So you can perform them in different positions. The therapist might be assisting them through the movement here, or be providing resistance. But just think of how changing the position will change the demands of the activity. So, this might promote a little bit more core and hip involvement than just doing like a seated activity. So always kind of consider performing these in different positions if possible, and depending on what impairments you're working on. Left-sided reverse chop. So this is why I kind of paused a little bit on the previous slide, because I realized I should have made it a right-sided reverse chop, just so we're kind of returning back to that position. But we've got a left-sided reverse chop, but it's bringing the upper extremities into a flexion diagonal pattern. So the involved side, which in this case would be the left side, is performing D1 flexion, which would be that reach up and grab your seatbelt. The uninvolved side is performing D2 flexion, which would be draw your sword. So that's kind of here. Again, they're kind of in the seated position here. So depending, maybe your patient doesn't have the hip strength or core stability to maintain that tall kneeling position, then maybe seated would be a better position. But definitely think of ways to kind of challenge them a little bit more with different position changes and things like that. So we talked about, those diagonals and the lift chop patterns are useful for mobility around the joints, and also to improve that multi-joint, multi-planar coordination that occurs. Moving on to this next section, we'll talk about different ways to improve stability. And these typically tend to be alternating isometrics, which are also known as stabilizing reversals, or rhythmic stabilization. So alternating isometrics is typically what I refer to them as. There is some kind of common words you might pick up on, like as we're going through these different techniques. One of them being stabilization. So when you see stabilization in the name referring to a PNF pattern, it's typically meaning that it has to do with an isometric contraction, maintaining stability through a muscle contraction. Anytime you see reversals, it usually means that there are a couple of different reasons you'll see reversals. For this instance, it's that what resistance you're applying is changing direction, so it's going from one side to the other. You might also see reversal as we talk about some other like means of strengthening, meaning like a reversal in just the movement at the joint or the type of contraction occurring, but we'll talk about that when we get there. But for this case, like stabilizing reversals would mean that isometric holds against resistance coming from both sides of whatever joint we're working on. Or it's also called alternating isometrics, which I think is the better term because it just tells you that you're getting alternating isometric contractions. So this can be done at the trunk, or it can be done at stabilizing muscles of the shoulder or hip. So it can be used in several different ways. But really, the manual resistance that you apply is going to be occurring in a single plane, and it's occurring on one side of the body segment, and then you reverse it to the other side of the body segment. So if we're thinking about improving sitting balance stability, this might be applied by somebody sitting at the edge of the mat table. They don't have any back support. You're going to push on the front of their shoulders, trying to push them back. They're going to resist it, and usually the cue is something like, hold, don't let me move you, as you're applying resistance to push them back. And then you might hold that for a few seconds, and then you change your hand position to be on the back of your shoulders and you're pushing them forward, in which case you give the cue, don't let me pull you forward, and then you kind of switch back and forth like that with those different techniques. So you're alternating from one side of the joint to the opposite as you're trying to push the patient back. Their rectus abdominis is going to be kicking in more as you're trying to push the patient forward. Their lumbar extensors and hip extensors are going to be kicking in more to prevent that flexion at the hip and at the lumbar spine. So this is useful to kind of isometrically contract and strengthen the agonists and antagonists. You can apply it to one extremity, to both extremities at the same time, or to the trunk. Again, thinking of like what position you have them in will kind of dictate like how much muscle mass is required if you're pushing at both extremities. So if you have somebody seated and their shoulders flexed to 90 degrees and you're pushing down on their arms, yeah, it's working their shoulder flexors because you're trying to push them into extension, so they're resisting that. But it's also going to be kicking in their lumbar muscles, because by you pushing down on their shoulders, their arms, they're going to have to resist that flexion moment at the hip and at the lumbar spine that you're putting on them. So they're going to resist that by activating those hip extensors and lumbar spine extensors. It would be even more so increased if you did that in tall kneeling. So, think about what your goal is, what you're trying to achieve with the patient. But this can be a way to isometrically strengthen the agonists and antagonists. So, it might be useful if you're working on shoulder flexion. Another use would be if you have a patient that's weak with shoulder flexion, maybe they can get up to like 110 degrees. You might have them come up to 110 degrees and then work on alternating isometrics by pushing them into extension and then pushing them into flexion and having them trying to resist that. So it can be done kind of within the sagittal plane. You could also have their shoulder flexed to 90 degrees, and you can kind of work more in like a transverse plane by trying to push them into horizontal adduction or horizontal abduction, just depending on what muscles you want to stabilize with this. So, again, it can be applied to several different techniques. I think Dr. McLennan does show both. I think he shows more the core one when he talks about rhythmic stabilization. So I think the core one that I talked about, seated edge mat, pushing forward and back, is shown more in the rhythmic stabilization video. And I think he shows like the upper extremity one in alternating isometrics video. Moving on to rhythmic stabilization, this is typically done to elicit co-contractions for stability. And I think a lot of these applications of it are more done, the resistance is applied more like in a rotational manner. And this is seen as a progression of alternating isometric because it, is a little bit more complex, and it's working against like rotational stability throughout the joint. And it does require a co-contraction of both the agonists and antagonists to maintain that stability. With this and with the alternating isometrics, it's not like an unexpected perturbation. They know it's coming. You're giving them the cueing before they do it. So it's more like kind of like an anticipatory kind of thing. Like they're giving the cueing, but you don't want to just quickly apply your resistance. You want to just slowly start pushing. And usually I'll just try to push a little harder until I feel them start to give, and then I'll know to back off a little bit. Again, with technique, applies to both of them. Just shift your hand placement opposite to the muscles you were just recruiting. So, from one side of the body to the other. And usually just cue the patient, like you gradually increase the resistance, but also gradually decrease the resistance. So you're not applying moderate amount of resistance and then just take it away and they face plant kind of thing. So gradually increase, gradually decrease resistance. Make sure that your verbal cues are kind of matching up with you easing off or increasing the resistance. This can be used to improve strength and coordination if people demonstrate impairments. It can be useful for range of motion deficits, postural stability and balance, decreased stability at a given joint. And it can also be useful, both of these, it can provide some feedback on, can a patient activate one muscle and then switch to activate the opposing muscles? Can they switch, turn off and turn on muscles as needed, depending on what stimulus you're providing to them? We'll kind of practice rhythmic stabilization a little bit more in lab too. And I think in the video, it shows more of a trunk application to this. We can also apply it to extremities, which we'll talk about a little bit. But the demonstration is, instead of both hands pushing from the front of the shoulder or the back of the shoulder, one hand is pushing the front of the shoulder, the other is pulling forward on the back of the shoulder. So both hands are working at rotating the patient. So it's kind of a progression because it's working on rotational stability, which tends to be a little more difficult and a little more challenging for patients with neurological involvement. But it's also both of your hands are providing a stimulus for rotation. So you can, not necessarily the patient can accept it, but you can provide more resistance because both hands are kind of pushing and trying to achieve that rotation. That was it for improving stability. Now we're going to talk about some different techniques that can be useful to improve strength throughout the muscle or through the joints. These can be applied during diagonal patterns, or they could even be applied during just any sort of regular uniplanar type exercise. It could be something that you could apply. So dynamic reversals, dynamic means we're moving, so we're getting an isotonic muscle contraction. The reversal here refers to that we're switching from an agonist concentric contraction to an antagonist concentric contraction to get bidirectional movement from the patient. So, this can be helpful for patients that demonstrate co-contractions. So maybe they're trying to work on elbow flexion, but their triceps just won't shut off. So it can be useful for patients that tend to have a co-contraction by having them focus on a concentric contraction in one direction, switch where your hand placement is, and work on it through the other direction. This technique can also be modified to work through a limited range of motion. So if a patient only has like 20 to 70 degrees that they can work through for elbow flexion and extension, then you can just provide the resistance throughout that range. Also, depending on the degree of resistance that you're applying, it can improve strength, and especially if you're working on like multiplanar, multi-joint movements, by applying that resistance, it can also improve their coordinated movement at multiple joints at once. And it does tend to have a degree, the patient's constantly doing concentric contractions for however many repetitions, and you can still use kind of those rep ranges we talked about in our first resistance training lecture, depending on if you're working on strength versus muscular endurance. But this does tend to kind of stress that muscular endurance due to the continuous nature of it. So to perform it, you try to get, kind of saying that example, the patient's triceps aren't turning off. We're trying to kind of recruit the biceps a little bit more. You're going to perform a concentric contraction of the muscle you desire to recruit first. So since we want those biceps to kick in, we would resist the biceps first. Get towards the end of the range of motion, I'm going to switch where my hand placement is to then resist elbow extension in the opposite direction. So again, kind of a tip provided here, and it's really a good tip for all of them, but just don't mix up your hand placement. You really want your hand placement to show the patient where they should be pushing, which will help give them some insight into what muscle needs to contract. So it can be useful. And again, this is done for repetition. So, if in this case, and they can't get the triceps to shut down in step one, you do triceps extension first. And then step two, you do elbow flexion. Not a big deal, because after that one, well, you're doing repetitions of this. So, you're just going to alternate between triceps contracting and biceps contracting. So, really, I don't care as much that, you should have done elbow flexion first, but you did triceps extension, because that's really just going to make a difference for that first rep. But the main thing with this technique to take away is that you're performing concentric contractions of the agonist and then the antagonist muscle as well. So it can be useful if somebody does have strength deficits, both in elbow flexion and elbow extension. Then you might get two birds with one stone by performing dynamic reversals within that strength training range by providing a little bit more resistance for that. You're going to both strengthen elbow flexion and triceps extension concentrically. It's not going to do much for the eccentric contraction of it, so I would keep that in mind, that if your goal is to work on eccentric contraction, then this might not be the most appropriate technique because you're only working on concentric contractions. So if that's the case and your patient, they're having issues with eccentric muscle recruitment, muscle activation, then an agonist reversal might be the one for you. So with this, kind of breaking it down, the agonist part of it means that it's the same muscle that we're working. We're still working that agonist muscle. So we'll use elbow flexion in this case. So the agonist would be the biceps, brachialis, brachioradialis. The reversal component here refers to that we're reversing the type of contraction. So we're moving from a concentric contraction where the bicep muscle is shortening to an eccentric contraction where the bicep muscle is controlling the lengthening of it. You might also see this called a combination of isotonics to kind of refer to the fact that it's eccentric and concentric contraction. So it's a different combination of those. But, this is truly indicated when you're trying to strengthen the muscle through a variety of contraction types. So typically what you would do, you would have the patient in the resting position, so the elbow extended as much as possible. You're going to have the patient concentrically contract the biceps against manual resistance. And then you're going to also you're going to still be applying that resistance for a brief end range contraction. So you might hold an isometric end range contraction for a couple of seconds here. And then what you're going to do, you're going to tell the patient, control me extending your elbow. They're going to reverse directions to an eccentric contraction, still using the biceps to control that degree of muscle lengthening. So again, this could be useful if you're trying to strengthen a variety of contraction types. Concentric, you do get an isometric contraction as well as an eccentric contraction with this type. Last kind of topic that we have here are different strategies or different techniques that can be very useful for initiating movement. We'll kind of talk through these. Again, that rhythmic initiation is on one of the upper extremity diagonal ones that Dr. McLennan is being the PT, is his wife on the treatment table. He does talk about using rhythmic initiation. There is a video on quick stretch, and he does also talk about repeated contraction or repeated quick stretch on that video as well. So there are videos for each of these. The only one that it's labeled is that quick stretch one. Rhythmic initiation is used to help when you're teaching a patient a new movement pattern or you're reteaching a movement pattern after some sort of neurological incident. It can be useful, but it can be an effective way of teaching the patient to do a movement pattern. It can be kind of a variety of impairments, but anything that's affecting the patient initiating the movement or performing the movement quickly or in the appropriate direction, or maybe they're just not getting a good quality of contraction, it can be used to kind of address all those issues. And kind of on the next slide, I'll kind of talk more about this point where difficulty is progressed according to patient response. Some patients, if they do have neuromuscular, their neuromuscular system's intact and, kind of have the primary motor cortex and lateral cortical spinal tract is intact, then you might get all the way through it. But if they've had a stroke or something, we might just get partially through kind of the progression here. But really, this technique is helpful for the patient to be familiar with the sequence of movement and the rate at which movement is to occur. It helps them become familiar with what you want to do. It might be useful if a patient doesn't do the best following just verbal cues alone. You can also use rhythmic initiation to provide some tactile and manual cues as well. So the technique, really what rhythmic initiation is it's the rhythmic portion refers to that you're doing multiple repetitions of it, but as you advance kind of through, as you move through the repetitions, you're trying to have the patient do more and more. So, typically it starts as passive range of motion with just the cueing, let me move you, and you're assisting the patient throughout the range of movement. As the patient's getting the hang of it, then you tell them, help me move you. And then they try to do as much as they can to help you move through that range of motion. If they're able to do it quite a bit, as I'm telling them to help me move them, I'm backing off on how much assistance I provide, to the point where if they're pretty much doing it on their own, I might just take my hands off and then they're doing that movement actively. If they get to the point where they're doing it actively, then I can provide some resistance and resist them throughout the range of motion. So it's a good way, to help a patient know what movement you're doing, to kind of help with motor planning and developing a motor plan for that exercise or activity, particularly if it's a new one like those diagonals. And it also would help improve coordination, especially if it is like a multi-joint, multi-planar movement. It can be very useful for initiation and coordination, more coordination of movement. And then sometimes people might not understand what you're saying and what you're telling them to do, but a lot of times if you can guide them through the movement, they'll get the hang of it. So sometimes multimodal cueing is required, and this can be useful for those patients that tend to respond better to those tactile manual cues than the verbal cues. So this is a technique I use a lot with stroke patients. And again, if they're pretty heavily involved, especially if they do have some lateral cortical spinal tract involvement or any of the anatomy along the way, we might not make it all the way to resisted range of motion. We're probably not going to make it to active range of motion that first session. But a lot of times we'll start passively moving them and then see if they can help at all. Talking about or thinking about the overflow and irradiation and how sometimes, usually after stroke, people have more strength proximally than they do distally. If I resist their shoulder proximally, then I might get increased overflow or irradiation to those more distal muscles. So, even if I don't make it all the way to active range of motion or resisted range of motion, if they're able to get somewhat to active assist where they're doing a little bit and they have pretty decent strength proximally, then I might even provide resisted active assist range of motion, where I'm resisting the more proximal segment, but I'm actively assisting the more distal segment. Quick stretch is another good one. Kind of thinking of the stretch reflex with the muscle spindle that we talked about. When we're stretching a muscle, we don't want that muscle to contract, and that's what the muscle spindle does. Is it detects a quick stretch and it activates the muscle being stretched, which can be a useful facilitatory technique if you're trying to get the muscle to contract. So really, by applying a quick stretch, you get a short-lived contraction that is really that stretch reflex occurring in the agonist muscle that you applied that stretch to. And it also provides or promotes that reciprocal inhibition or shutting off of the antagonist muscle, which would be resisting that movement. So, typically with this, and Dr. McLennan shows this as well as the repeated contractions or repeated quick stretch in the video. You're applying if it's just the quick stretch technique, usually at end range, you apply that quick stretch to the muscle to facilitate that contraction, and then which can help the patient initiate the movement. And maybe if they get that initiation, they can kind of keep going through the movement. Oftentimes, though, you'll get that short-lived contraction. So you might get that, and they might get a little bit of the movement. So if they're getting part of the movement and then their muscle isn't working or kind of shuts off and is not helping with the movement, then at that angle, you can apply another quick stretch. So you apply another quick stretch in the opposite direction. It gets that muscle to kick in a little bit more. When their muscle effort is decreasing, then you apply another quick stretch until you get through the range of motion. So, the initial quick stretch that we talked about is just applied typically just once, and usually it's more like the end range or the beginning area of the movement. Whereas that repeated quick stretch is applied throughout the movement to activate that muscle throughout the majority of that movement. These are the references here. Again, just kind of look through the videos that are posted on the Canvas page, kind of look through this as you go through it. If everything doesn't make sense to you right now, that's fine. I don't expect it to, unless it is something you've seen frequently in the clinic. But hopefully when we get to lab and would go through some of the lab activities, it'll make more sense, and just how you could apply it to different patient populations will make more sense. Again, if there are any questions, feel free to reach out to me, even prior to lab if things are bothering you, but especially after lab, if you're still having some trouble kind of grasping a lot of these techniques. That's why I didn't want to give this lecture to you the day before a test, because I don't know how much of it would stick. So I'd rather you have this, and it might make it even easier to flip back and forth between the different videos. I talk about it a little bit, and then you look at the different videos from Dr. McLennan. But good luck to you all. If you're watching this before the test, good luck on the test. If you're watching it after the test, that's probably what I would have done as well. Hopefully you did great on the test, but I'll see you all in lab.